Now it's time for our panel of experts to come up for the question and answer session.
This might be a little bit if you've ever taught Sunday school and you ask the kids next week what you talked about last week and they don't remember. So you're going to have to search deep in your memory before dinner and try and come up with some intelligent questions.
Dr. Ali, I wanted to ask you a question. Did I understand correctly that in the initial scoring you picked all calves that looked abnormal to somebody to find your cases and controls? Was that what you did?
So the question, if I understand correctly, for the first study, did we pick cases based on abnormal walk-by? Is it the first study you're asking on, sir?
Yes.
Right. So for the first study, actually all the calves were looked at initially, and if they had any of the clinical signs, they were then scored. And so they did not have to show as ill as in the second study. Does that answer your question? Right. Absolutely. So all the calves that looked abnormal were scored finally, and based on the score, the Wisconsin score of 5 or greater, then they were a case.
How are you inducing the cough in the respiratory scoring?
Question is, how am I inducing the cough in the respiratory scoring system? When you're in the pen with the calf, it's the upper trachea where there's very little skin over it. Compress it, shake it, let it loose, and a single cough is a 1, that's probably normal. Repeated coughing is a 2, and then obviously you don't even need to induce a cough. If outside the pen you've already observed spontaneous coughing, that's a 3. It's a firm squeeze though. When I train people to do it, I squeeze the upper arm and they go, ow. So.
This question's for Mike. Have you seen supply chains start to request animals that have not had any antibiotics besides these natural programs?
I have not personally worked with one that is moving from no growth promotions in the United States, December 2016 anyway. So moving from that within a supply chain that is going to allow other antibiotic uses, I have not yet been privy to discussions from one that is moving in that direction. I think if you look at the bellwether for where things are pushing, go to thomas.gov within the Library of Congress, look up either Louise Slaughter, look up Louise Slaughter and look down through her bills, and you'll get the PAMTA, Preservation of Antibiotics for Medical Treatment Act. And that is basically the manifesto, and I use that term intentionally, for what they are looking to do, and in that is no routine preventive use. And as I see the conversations that are moving around, I think as in the next wave of supply chains looking to differentiate themselves without going to natural never ever or an organic type production, that's the next step. And it's very clear to me that what we're getting engaged in is what's the next step to differentiate themselves as being socially responsible or moving to the next step. And that's why I make that prediction of where it'll go.
This is a question for Dr. Knopfsinger. How expensive are those stethoscopes and the software?
The question, what is the cost to the whisper technology? You need to check with Micro. They are marketing that. That initial equipment layout, a computer and the stethoscope instrument would be in the neighborhood of $1,000, and the other fee has to do with service. Those fees are based on inventory, cattle inventory.
May I ask a follow-up on that whisper question? What are your auscultation sites? You said 8 seconds, and then what are your auscultation sites to give you that score?
The question is, what are our auscultation sites, and how do you work the 8 seconds in there? The software has been written based on the fact that most BRD in beef cattle starts in the right apical lobe. So we're in the neighborhood of the elbow. Usually on a 6-weight calf, we'd be 2 to 3 inches above the elbow. There is a lot of variation in heart function in these cattle. So we ask our people, if you place the stethoscope on there and you get primarily heart sounds, that we then move that stethoscope a half inch or an inch upward, so that the filters that filter out the cardiac sounds don't exclusively take out some of the air sounds also. So we train our people to try to place that stethoscope on there in a very firm fashion. When the audiogram comes up on the screen, there's a black line under the audiogram that illustrates what percentage of the recording was high quality. So if the animal moves, or he coughs, or somebody asks the animal to move, then you can see that you need to retake the sound. It creates it requires a mentality within the crew. Obviously, if you have 600 pounds of hydraulic pressure on the rib cage, this technology doesn't work. So the first thing we ask people to do is, when the animal stops, we release the squeeze. And it's okay for sick animals to be able to breathe. And then we place that stethoscope on there, and we ask people to work as a team. If you've got a team member that puts the ear tag or the implant in when you're listening, you have a heart-to-heart discussion with those people. Well, it takes cooperation.
Dee, I've got a question about the lesions in cattle that were untreated. I've got 2 questions. I'll ask the first one. Did you know origin of those cattle? Were you able to trace back and say, were these high-risk cattle, low-risk cattle, et cetera?
Sometimes.
Okay.
In Dr. Bryant's work, a fair number of those cattle came from the U.S. Meat Animal Research Center. And those cattle have, they're observed every day. And I, over the years, have come to believe firmly that the cowboys we have at the U.S. Meat Animal Research Center are as good as anybody ever set a horse. They're certainly dedicated, and they know how to deal with research protocols. So he had information on all those cattle, and in that first study, 72%, if I remember right, it was 72% of the cattle that had been observed for having BRD at some time in their life, maybe not treated, but they usually, at least during that time, were asked to record, did you see anything? Even if you didn't want to go chase this calf down, suckling the cow. And those are, but nevertheless, 72% of the cattle that had been observed sick had visible gross lesions in the packenhouse of some kind. The thing that was disheartening was that over 50% of the cattle that had never been observed a day in their life had lesions.
Has anybody looked at what I would consider the lowest risk calves. So let's say a cow-calf producer had 100 cows, finished all of his own calves out, bought nothing, just finished out that group of calves and looked and seen what percentage of those calves had lung lesions. Because again, when I was in practice and I dealt with those kind of people, we had many times we treated 0 calves for BRD. But has anybody looked at lung lesions on that low risk kind of calf?
Yes, and again, you're right back to the Meat Animal Research Center. I will use that data. I will use that information. Since that original Bryant study was done, in those calves, because of the study, nothing was done to them. I mean, nothing. So the standard protocol that the veterinarian responsible for all the cattle at the Meat Animal Research Center has in place for vaccination of cows, subsequent vaccination of calves, multiple times, we get to now look at low-risk cattle. I mean, there are times we'll have lots of groups of cattle in which the highest disease prevalence we have for anything or health recordings are for things like they have feed blown in their eye or a sore foot. It's not respiratory disease. So the protocols work quite well. And if you look at those cattle, and I can't tell you what those are, they've spent all summer looking at that kind of stuff, but those numbers are pretty low. If you take care of a calf right, they don't show up. I do have a couple of feedlots that are nice enough to let me go chase cattle that they have veterinarians on their end talking to veterinarians on the other end and working out coordinated efforts. It's boring as hell to look at those lungs. You know, it really is. And if the nutritionist is not around, it's boring looking at the livers too. You know, so sorry.
The respiratory scoring system is very nice, but I was just wondering if there's any data to where failure of passive transfer kind of fits in the equation there.
I think you want me to start with that. The relationship between respiratory disease and failure of passive transfer, I think that there's not, to my knowledge, there's not an exhaustive study. I did not look at those data. My sample size is much lower number than Sharice's has. So did you sort your data for failure of passive transfer? We have that coming up in a trial that we're doing right now, but I can't tell you what the relationship is. What I always remember is that IgG is the major immunoglobulin in the upper and the lower airway of the calf for the first 6 weeks. So I do think failure of passive transfer puts calves at higher risk for respiratory disease. And we for sure know there's data to, even if failure of passive transfer isn't a direct risk for respiratory disease in the calves, calves that have diarrhea are at a much greater risk of getting respiratory disease.
And then I'm remembering Louis' graduate work. Yeah, and that's FPT can be shown up in the feedlot. You probably remember more detail.
Yeah. One of our good old friends and mentor, Louis Perino, had done a study from between 1998 or 89 rather than 91 that looked at failure of passive transfer. And again, I'm back at the U.S. Meat Animal Research Center. That's an amazing place. I don't work there. I'm a Southeast calf, and that's lower quality than they want working for them. But they demonstrated not only did failure, and they were looking at 800, 1,200, and 1,600 cutoffs, that not only did failure of passive transfer have an effect on things like diarrhea, that effect carried over into the feedlot. And I can't figure this one out. I just trust Dr. Perino and his statistics since he's pretty anal about that stuff. There was a statistically significant difference in foot rots in the feedlots related to after weaning, related to the absorption of colostrum. And what in the devil colostrum's got to do with foot rots when a calf is 6 or 7 months old, beats me. But in this audience, we have Dr. Renee Duell, and you guys ought to capture her. She did a very exhaustive study, or a much more exhaustive study, under the supervision of Dr. Laura Hungerford, who's now Maryland/FDA, phenomenal epidemiologist. And part of, and I don't want to mess this one up, it's published in AVMA journals, but they went beyond 1,600 as a cutoff. And if I remember, the bottom line was they never found a top. In other words, if you got 2,400 in those calves, the calves performed better, and it was measurable on the scale as well as the disease occurrence. And they followed them up to over 3,000. So you might talk to Dr. Duell, or go chase her name down, Dr. Renee Duell, in AVMA website.
Yeah, I've got a question for Dr. Ali. Could you please explain how you define your case in your scoring system development? More precisely, I'm wondering, why did you choose a cattle as only PCR positive for BRSV as case?
If I understand the question, it's for me, right? The question is the reasons for choosing a case being PCR positive, and why especially BRSV? Well, I guess from the pathogenesis, right? So IBR and BRSV are not normal inhabitants of the respiratory system in calves, and they should not be. So why especially BRSV? That was the only virus that we got on the first study for the 2,000 calves. We didn't have any BVDs, we didn't have any IBRs, right?
So in other words, you never find BRSV in sort of LC calves, really LC one, just PCR positive BRSV1, because I found a lot of calves that were pretty LC with infected by BRSV. So even if they look normal, in the case of, that's why I asked you this question. So
that's a very good point. So it could be very well that they're BRSV positive, but maybe they're not showing clinical signs. So from that end, the reference status is what that dictated the reference status. In a sense, any abnormality from that, any deviation from that, would go into the false negatives. So in a sense, the sensitivity and specificity were based on this algorithm for the first study, it was an attempt to modify the initial classification based on the Wisconsin scoring system. There's something called inclusion bias. If you go do a study and you come up with a scoring system, using a scoring system, you can't estimate its accuracy based on that scoring system. We have to deviate from it. So what repercussions will that have? Well, the repercussions are probably all the way up until we say the cutoff is 5. That gets erased in the sensitivity and specificity that I reported in my second half of my study, because that was based on ultrasound and auscultation. See, we really needed to deviate. Once you call a set of calves of positive BRD and negative based on Dr. McGurk's scoring system, we develop a new scoring system based on Dr. McGurk's scoring system. We can't come and say it's 100% sensitive based on Dr. McGurk's. We have to deviate. We have to change the classification of calves. So the most logical classification we saw was something like coronavirus, for example, which we see quite often in the tract. I think that would be a great example, like you're saying, where we see positive cases and they're not positive for coronavirus and they're not BRD cases at all, neither clinically nor histopathologically. So from that end, we did not choose a virus like coronavirus to classify the calf as positive for BRD. We chose only viruses that based on what we know from the pathogenesis of the disease, that if IBR is present, and it's not just intermediate, it's actually strong positive on the PCR cycles to threshold, then it's probably positive. We did not find any IBRs. It was only BRSV. I think, Dr. Vaniam, you have a question, or?
This is for Dr. Ali and Dr. McQuirk. You mentioned your concerns over biosecurity, and then you have this scoring system where you handle these calves or appear to handle these calves. How do you achieve a balance between your concerns over biosecurity and the other pathogens that you have out there with your employees doing what they're doing in the scoring systems?
It is a concern. Well, the first part is that if we reach a positive score from outside the pen, we don't go in the pen. That's one of the modifications. We examined other ways to get temperatures, so we weren't in the rectum. But basically, the examiners wear gloved hands. If the calf suckles, we change gloves. We wear the same boots from pen inside the pen, one pen to the next. So there are drawbacks along with the advantages, but you have to weigh that there are potential negative consequences. But from the perspective of the examiner, spreading it from calf to calf, the one thing is that we change the gloves.
I totally agree with Dr. McGurk. So from our end, and in California at least, and probably the states around us too, the large number is what really dictates having to simplify the system from that end. And so, like Dr. McGurk said, if there's enough clinical signs adding up to the total score, to the cutoff, then there's no need to jump into the hutch and get a temperature. Maybe some more analysis needs to be done, at least from our end, looking at when is it that, how often was it that we needed to go in and get a temperature. But from that end, this was a comment that we had from the managing team for the calf ranch, and it's understandable. We're running 2,000 calves, so walking basically every day. Dr. Lindbauer, you know more than I, about 40 rows, each row about 400 calves. So walking all this every day is just impossible, actually physically impossible to jump into every hutch. So at that point, the goal was to try to minimize that.
The other thing I might add is that just in the regular management of calves, the delivery of food, the traffic of the people taking care of the calves, the twice-a-week screeners might fall lower on that scale of being potential spreaders of disease. But you maximize the best practices for everything you implement.
Hello? Yeah. Hi, this question's for Dr. Nufzinger, a little bit due to your comments, Dr. Apley, and that is, how are you managing your natural cattle without metaphylaxis and antibiotics? And does that system work if you don't have the conventional supply chain to put the fallouts into?
The question is, what procedures are we using to manage natural cattle? One of the things we've learned early on, and Dr. Kev taught me in Australia, is first try not to ever put animals in a position to fail. So we wouldn't go buy highly commingled sale barn cattle to put in a natural yard. And as people create relationships through procurement, just like Dr. D said, if we can have repeat customers, repeat suppliers, and work with that veterinarian or that producer, and it's quite rewarding to see what happens when we vaccinate animals before they're ill. And so if we can go down the supply chain, those things are much more important than the actual treatment of the individuals. The other thing that we've done recently is we have a nutritionist that will cooperate, and he formulates completely new diets for these natural cattle compared to conventional cattle. They are ruminants, and so procurement, cooperation, changing the diet, and then having confidence that these animals with very, very mild respiratory signs, usually a vacation on a different ration with some rest and water and care is effective as treating those. We are blessed in several of our natural yards where we have other conventional yards in the same system, and that really is handy too. So, thank you.
I had a question for Drs. Ali and McGurk. I think both of you said that assessing appetite was not a particularly specific sign. I think a lot of calf raisers that I know would say it's at least a very sensitive sign of a calf that isn't feeling well if it doesn't drink its milk. I wonder if you could comment further.
You note I tried to pass that off, Walt, but the appetite-based scoring system, perhaps it will be better as we feed calves more to potential and have higher protein, higher fat milk replacers and feed more volume. So I think as we progress in nutrition, the ability to detect calves by appetite, either refusal, slow drinking, may improve. Certainly under traditional systems of twice-a-day milk feeding, whether higher volume or not, it's rare until very, very advanced that a calf doesn't go to the bucket or is slow to consume. In an extension presentation at for States Nutrition Conference, the Iowa State Extension Group did a report of automatic calf feeders and reported that the appetite-based sensitivity tools, or their ability to pick up calves with respiratory disease by the flag computer, either volume or frequency or time to consume, also missed respiratory disease. And that has been my experience with automatic calf feeders. In fact, to the point where we say, when we're doing the twice-a-week screening, the screeners go in and do the respiratory detection before they look at the computers. They use the computers for the daily exam, calves that need a daily exam, but they look twice-a-week screening. They do it from inside the pen first.
So I guess what I want to add is there's possibly other reasons for a calf to lose appetite, as you clearly stated in your talk too, that diarrhea and other things. So from that end, at least in enrolling calves for the second trial, appetite was one of the initial reasons to flag calves. It just wasn't the only one, just with the nature of BRD needing to confirm it. So loss of appetite, depression, just the calf not looking quite well or bright. And then came the secondary exam of using ultrasound and auscultation to finally put a diagnosis on it as BRD. So I guess for the first calf ranch study, it was not used, but for the second study, the sensitivity and specificity, all 523 calves were flagged initially based on 3. Did not feed, have that milk diet that morning or that afternoon, morning because we walked in the mornings, did not feed, did not look bright, and just looked ill. Maybe just one more comment about failure of passive transfer. I just remember now, we actually, there's quite a bit of colostrum trials that have been done, and I want to say that I believe the majority of them point at that association is actually significant. So from our end, we probably enrolled in the last 4 years about 750 calves in different trials, but amongst these, I think in both of them, we had positive significant association in increased risk for BRD. Of course, with diarrhea too, there was significant association.
Tom, if we open the thorax and look at the lung, it's difficult to know what antimicrobial to pick. If we culture the lungs many times and run sensitivities, it's difficult to know what antimicrobial product to pick. How can we pick it with a stethoscope?
It was a big surprise to me, Dr. Dell, when we first started doing this, because we'd have relatively severe lung score 3 or 4 cases on entry into the hospital, and my caregivers would ask, how soon can I listen and hear a change if the antibiotic is working? And I didn't know what to tell them. But what has always amazed me is if we handle the cattle correctly in the hospital and we treat them appropriately, we should expect rapid improvement in lung score within 24 to 36 hours. And so and if in fact we've treated an animal with an antibiotic and that lung score does not improve or worsens in that 36 or 72 hours, it's going to be a tough row to hoe. So we expect a rapid improvement in lung score with effective treatment.
I'm curious about the Wisconsin calf scoring system, what the uptake has been of that program and what kinds of operations have successfully deployed it, and how you incentivize and keep the enthusiasm, how some of those people have incentivized people to stay enthusiastic about it. Just curious.
How does the Wisconsin scoring system, how well used is it? How do you keep people using it? What incentives? It's wherever we've had a chance to look at scoring or respiratory disease as a problem, I would say without exception it was adopted afterwards. Then comes a step of modification of the scoring system, and so it'll be used in different ways, shapes, and forms. Some dairies use it if they don't see abnormal discharge, they don't go. So there are lots of little modifications. Basically, it's about the labor and the people able to accomplish it, and that's the hardest part of this. But the results of having ear infections go away, a lot of those are the growth, the weight change at weaning prior to the implementation of the regular screening, rewards for lower cases, treatments, a number of things like that have kept it going. But it's not 100%. That labor, the need, and the incentive, the internal, external, real objective rewards are an essential part of that.
I have an unrelated, well, it's related, but not with that. And I'm not sure that I want to say it's the elephant in the room, and we've alluded to it, but I don't think you can have it, and this has nothing to do with my talk, but I'm not sure you can have a healthy calf unless it's born to a healthy mother. And I don't think we've got any conversations back and forth today about how you have a healthy mother. At least haven't so far. And I don't. And a healthy mother starts because she was born a healthy calf. So when you start with this chicken or egg thing, it has to do with how you take care of those expectant mothers and those babies when they hit the ground being treated like they're going to be an important herd addition at a later time in their life, such that they get that first 24-hour start is a good one with lots of colostrum. I mean, I remember when I was in school, if they don't nurse in 6 or 12 hours, we'll go get her up and, and we'll tie her in a corner. Of course, in Oklahoma, we'd tie her to a tree, and fight out the milk and poke it in the calf. Some of the work that's been done at the U.S. Medical Research Center has convinced me that when that calf, if I'm there, if whatever the situation says that I need to be there to assist that birth, then we're going to milk that heifer or cow, and we're going to put it in that calf. And the milk out of some of those heifers, there may not be a pint of it, but it's so thick you can't pour it. So you have to rinse out the bottle a couple of times to get it all in that calf. Now, I don't do the milking. But, all the cowboys we hire at the U.S. Medical Research Center, they have this longing to milk heifers. And the genetic structure of our heifers are that they want to be milked. So it's been a great addition to the change in the way I approach management of heifers. But I think it's critical. It seems to me like that unless we manage the herd, that you can't expect to have healthy, disease-resistant calves And part of that herd is, we haven't said anything about it, but if you've got persistently infected BVD cows in your herd, you might as well pee up a rope. I mean, it's not gonna help you. I'm sorry, it's not gonna. You got to do the little things that require you have a chance at having a good calf. And there are a number of things like that we all know about. But all the vaccines in the world that Pfizer or Zoetis or whatever their name is this month produces is not going to give us a healthy calf unless we've got a chance. And that starts with management of the mom.
I wondered, in our calf raising in the East Coast, one of the parameters that we measure fairly regularly is the doubling of calf weight within 60 days. If you're achieving that goal, do you think that that you should start to implement a scoring system if you're in large numbers?
In general, if you have performance that doubles weight and not treating disease, probably not going to be, whatever they're doing is working nicely. Sort of, I think what Mark said, when the pieces start to fall apart on the plan, you got to have something to resort to. But if it's not broken, the urge to go in and fix something is much less significant in my view.
Okay, how's that? Good. This might not be fair to ask you right after you've just given these talks, but I'd really love to hear each of you say what you think would be the most important thing to help improve accurate definition or accurate identification of BRD in the populations you work with.
Really? I guess you said in the populations we're working with. So from our side, again, the challenge is the numbers. So covering a large number of calves in that short period of time after feeding or right before feeding. So from that end, and cost, of course. So I don't know if, probably cost is a common factor across this table, but in keeping BRD prevalence acceptable, control efforts starting with the dam, the calf environment, housing, nutrition, all these factors will, I see especially larger, more specialized calf ranches try to standardize and fix and to make them constant, to minimize variability. I don't know if one specific tool is the answer. I'd like to tell you BRD3 is the answer, but the reality is, at least from what I see producers do, they get a good hold on these variables and they try to make them constant, keeping in mind cost and labor. So I don't know if that answers quite, but.
For me, on the feedlot side, I think it's something that takes us away from the classic cowboy spot them, pull them, and treat them. There's several neat systems being worked on out there, some of them public, some of them not so much yet, that are taking us to parameters correlated with the potential to become a BRD case that aren't involving the potential to or the need to have to actually spot them. And in seeing feedlots that were used to handling Holsteins and then bringing in a couple pins of rounded up by helicopter southeast Bramer cross heifers in heat, and they would not pull them when they perked up, to go over there, which was until they were about dead, wouldn't perk up. So I think those are really the our future benefits in that. And the other thing that strikes me is we've developed so many ways to push these calves physiologically. I think looking at the fact that there's some calves we just can't push as much, and getting that last eke and little bit of performance out of them causes us a lot of grief on the health side. And I know that's old knowledge for people, but I think that's something I'd like to hear us talk more about.
Amelia, if I heard you correctly, you said a definition, a disease definition. Is that correct, what you wanted? Regular screening of calves, looking for cluster of, in the dairy calf, pre-weaned or post-weaned, looking for a cluster of clinical signs, and then having an additional tool, I think, that will serve as a more or less a confirmatory test in a clinical patient. Ultrasound picks up the lungs. It will miss upper respiratory, but airway sampling of some variety that has relatively good sensitivity and specificity in the live animal to couple with a cluster of clinical signs.
I think there's huge potential in, at least in feedlot medicine, for more training and empowering caregivers to understand that their relationship with those animals can be either positive or negative. And so if you compare a pin rider riding randomly through a pen of cattle in no set pattern just to make sure that he saw every animal, saw the tank and saw the bunk, compared to taking newly arrived cattle and putting them in the corner and asking them to walk by and making sure that the cattle and the person know what can be done, all of a sudden those cattle are a lot more willing to communicate. I think that if we receive cattle that we know are high risk and we don't have time, we don't have 48 hours to determine that true state of health, then we can use ultrasound or auscultation or thermometer or whatever, but we need to identify those cattle on arrival. And we know that if they have a lung score 3 on arrival, that 3 or 4 or 5 days ago in Alabama, they were starting to get sick and were already behind. So I think it's, if we have cattle that are coming directly from a farm, we have time to create a relationship between the people and the cattle, and if that animal understands what is expected of it, and that person understands what is expecting of he or she, it's pretty simple for those people to find animals that deserve extra interaction. And what those people are trained to do is go find the animal or two in a pen, say hello to it, and take it for a walk. And in 4 or 5 steps, that animal will tell you whether he has BRD or some other thing. It's really important that these people be taught to think in systems. So when they see an abnormal animal, they need to think about locomotion, digestion, respiratory, cardio, CNS. If they see an animal that's unwilling to communicate with a caregiver in an expected fashion, then they think through systems, and then we give them tools to document what is going on in that animal prior to the chance to necropsy him.
I love Tom. I wrote down 3 things, and I think it applies to Dr. King's or Engler's 500,000 head, or Dr. Hilton's 150 head stocker, somebody's hand on the farmer feeder. It seems to me that the biggest deficit we have in every place I visit is stockmanship training. Once upon a time, we happened to think that everybody learned from Grandpa how to do stuff, and they may well have, but the labor force we have today didn't have the same grandpas that I had. And I'm not sure that Grandpa and my father taught me how to... There was nothing about my father that was low stress. All right. So I think if developing a training system that teaches people stockmanship may be the biggest addition we can have for giving somebody the opportunity to find a sick calf. If they don't possess the stockmanship, they couldn't find it with both hands, and it was the only calf in the room. That's one. Number two that goes with that, which is part of what my dad did tell me that was useful. I mean, he told me a lot of things that was useful. He went to his grave, no more cattle than I ever will. But he told me when I was about 16, and I was real busy, if you don't let cattle get to know you when they don't need you, they will not let you know them when they do. I heard that over and over and over. So when you get new cattle in, cowboys and cattle need to get to know each other, which means that they need to spend, instead of just dumping them in a pen, you actually spend a little time in that pen going, hey, I'm the guy that's going to be looking after you, and we're friends. And this is Trigger. And let me go show you where the water tank is. And maybe I ought to go show you where the bunk is. And spend time with those cattle, letting them get to know you. So 3 or 4 days later, when you walk in there, he actually will hold his head down so you can see him. And not just raise it up and go to the bunk. That would be my number 2. And my number 3 is just that. We get so busy. They need time. Time to get to know the cattle. But when they ride in a pen, they need to have time for cattle to look at them and for them to look at cattle. Time. And I think we push some of our caregivers, as Tom calls them, to push a clock faster than maybe it ought to be pushed sometimes. So those would be my 3 things.
Just one more question here, or 1 or 2 if it's quick.
Can I go? Dr. Griffin, I agree with you that it all starts with cow-calf, and I think the research on fetal programming is going to be very exciting. I do respectfully disagree with you, though, about your beef cow-calf example about tying a heifer up that needs, everything. And I think our industry should not tolerate a calf without calf vigor. I think we need to develop a calf and a cow that thrive in their environment, and if they don't, some cows are asking to leave the herd. So, if I got a heifer that I got to tie her up and get the calf nursing, that's her last calf she'll ever have, and that calf is going to have his nuts removed, and he's going to town. And I just, when I see how low maintenance some of our people run their cattle, I think you know what I'm talking about.
Yeah, and I don't know that we disagree at all. But if I've had to spend any time behind a heifer to deliver that calf, everything about that experience is not what God programmed in her head. She had spent a month or a week or some time figuring out where she was going to have this calf in that pasture. And we screwed all that up. So the nest that she was building is no longer there for her. And now then she's had the cowboy who's I don't know what he's English leather he's wearing, I don't know, but it smells funny. And a cowboy has no appreciation for a calf jack. You can hang a calf jack on the back of a cow and just let it hang there. That's 250 pounds of pressure pulling on that calf's leg. Well, they can step on it and bring it to 1,000 and smoke 3 cigarettes and eat 2 peppermints while they're doing it. And that calf's not designed for that. And so when he gets out, he's not exactly vigorous to stand up and want to nurse. And she wants to go to the back 40 because she's scared. So from my standpoint, before we ever let Mother Nature get to know each other again, let's go ahead and get some milk out of that heifer and put it in that calf who's too sore because we did a crappy job of pulling that calf. Not everybody. I'm just saying that happens sometimes. His little joints are sore. Let's get something in him right now. And you're right. If we've got crazy cattle, that not just cattle. There are people like that out of too.
I agree. It's just really fun for me to go to a herd where they've allowed us to be partners in their herd to prevent things, and I say, how's the health of the herd? And they say, perfect. We didn't have any sickness last year. We didn't have to pull any calves. Everything went as planned. And it takes a while to get there, but I think sometimes we forget. I asked my first-year vet students when I talked to them, what's an acceptable level of calf diarrhea in a beef herd? Almost nobody ever says 0. And that's the number. In a beef herd, the acceptable level is 0. And I think sometimes we set our standards too low.
Okay. I'll try to make this quick. So my question is with regards to the subset of cattle that have been treated but don't have lung lesions at slaughter. First of all, are there enough of those cattle to even bother thinking about? Second of all, do we know anything about their performance? Do they have decreased performance in the feedlot? And if they do, what are we missing? Do we think they had respiratory disease that didn't result in long-term lesions, or what do we think is going on with those cattle?
I'm going to let Dee answer this, but if a lot of those cattle are the star performers, some of those animals that have been selected to gain 6 pounds a day have a little less disease resistance. And if you can identify those animals and treat them before they have permanent lung damage, the respiratory treatment was actually positive. And so those cattle outperform their cohorts. There are many cattle where I live that are treated with mild or have mild acidosis, and they have a little extra lung sound, a little bit of fluid there, and they need a bale of hay. So.
Tom said that right. In the numbers that Perino and others gathered at the Meat Animal Research Center back in the early 80s demonstrated that some of those cattle may well have had some histologic lesions, but not visible grossly. But we do treat some calves that we don't, they were just missing their mother, and somebody thought they looked depressed, and here you come. And LA200 can't hurt anything, right? Well, at any rate, we do treat some that don't. And I love the idea that we end this talk on, or this session on, remember, subclinical acidosis, which is the purview of the nutritionist, can look like respiratory disease.
I think with that, we'll end this session. Let's give our session speakers one more round of applause.